Good morning, good afternoon, good evening. Today is Human Rights Day, an apt opportunity for WHO and partners to focus on the Global Health and Care Worker Compact. Health is a fundamental human right, and as WHO Director General Dr. Tedros often says, there is no health without health and care workers. People-centered health systems must include and engage providers and recipients of care. It's in everyone's best interest to invest in health and care workers and to safeguard their rights. At the 74th World Health Assembly, the world's health ministers called for a new global health and care worker compact, recognizing and concerned with the enormous challenges borne by health and care workers during the COVID-19 pandemic. These challenges to both health and care workers and to the human resources for health community are not new, nor have they disappeared. If you look at the headlines, even over the past week, last week, one country banned midwives who are predominantly female and who support the right of women to safe pregnancy and childbirth from working. In the ongoing MPOX public health emergency of international concern, health workers form more than 4% of cases as of the end of October. More work is needed to strengthen occupational health and safety. This week, The Lancet published an article on whether one high-income country's health workforce can keep up with demand. They cited poor and insufficient staffing and its frequent partner, burnout, as reasons for departure from service. Situations of fragility, conflict, and violence continue to wreak a hideous impact on health and care workers, who at times are targeted for their service or are ancillary casualties of attacks on health facilities. This is 160 years after the Battle of Solferino, 75 years after the 1949 Geneva Conventions and their additional protocols. The world must do better to protect health workers and civilians from the barbarity of war. The Global Health and Care Worker Compact provides recommendations on how to protect health and care workers and safeguard their rights, and to promote and ensure decent work, free from racial and all other forms of discrimination, and to provide a safe and enabling practice environment. Today, I am pleased to moderate this august panel of experts from WHO, academia, government, and health worker unions, who are some of the key stakeholders that contributed to the development of the Care Compact. They will be critical in advancing progress in strengthening political support, policy change, and action to realize the promise of the Care Compact, that governments and employers exercise their duty of care and use law to protect and advance the rights of workers and improve health system effectiveness. I'm Catherine Kane. I work at WHO as a technical officer for the Global Health and Care Worker Compact, and I'm delighted to moderate this panel today. We will have 5 panelists, as well as live translation in French and Spanish. During each presentation, we'll be putting up polls, and we hope that you'll take the opportunity to respond to these polls and give us a sense of what you're seeing. We also will have a Q&A function where you are free to put in questions that you'd like us to pose to the panelists. We'll answer some of those in the typed comments, and then we'll also answer some of them live. We are trying to prioritize interacting with you and really getting to your questions and answers. So I hope that you'll be hearty in your submissions, and we'll be distributing those to the panelists. We look forward to speaking with you this afternoon, to making sure that we have time to talk to each other. And with that, I'd like to introduce Dr. Matt Cavanaugh. He's the director of the Center for Global Health Policy and Politics at Georgetown University's O'Neill Institute and School of Health. Dr. Cavanaugh is the lead author on the groundbreaking Health and Care Worker Legal Environment Study, and he'll present key findings. Over to you, Dr. Cavanaugh.
Thanks very much, Catherine, and thanks to everybody who's joining, and thanks especially to the partnership at the O'Neill Institute and the Center for Global Health Policy and Politics at Georgetown University, and to everybody at the World Health Organization. This has been a real amazing work together to try to think about how would we measure the environment when it comes to health and care work around the world, how will we get a baseline for it, and how will we know if progress is happening. I'm Matt Cavanaugh, as was said, and I'm really glad to be able to present some of the kind of key findings of the work that we've been doing with colleagues. As Catherine said, the Health and Care Worker Compact has really attended to 10 different areas when it comes to the rights and the protection of health and care workers. For each of those, there is existing international legal commitments where member states have said, we are going to protect workers, we're going to recognize rights. That have wide recognition globally. And in addition, countries have adopted the approaches that of trying to have a compact under the leadership of the world's health ministers in order to advance that even further. The core contention here is that law is a determinant of health, and that protection and rights are determinants of health and care worker retention and their effectiveness. And so for each of the 10 areas of the Global Compact, what we've done today and that what we'll be presenting is a new analysis that's out as of today in PLOS Global Health that looks at 182 countries across these 10 indicators and asks, how well do national laws address the rights and protection of health and care workers? How well is the world implementing the Care Compact at the national level? Using policy surveillance methods, we have done an empirical analysis that covered 182 countries. It covered 1,262 individual laws, which were gathered by teams of lawyers and researchers looking at government documents from around the world. And so a huge thanks to all of the colleagues who were part of that gathering effort. It was massive. Thank you to World Health Organization teams who were able to feed back on a lot of it, as well as some of the unions and civil society, as well as governments that were able to share documents that enabled this to happen. And if you go online, you can see the full article. It's both online at our website at hcwpolicylab.org and at PLOS Global Health. So what did we find, having looked at the world? Well, one way to measure overall is that of those thousands plus laws that we looked at, 62% of them we categorized as aligned with the Global Health and Care Worker Compact. That is a kind of one baseline understanding. Now, that's not 62% of countries, that's of all the laws. So if we just imagined all of the areas that we looked at, we found that about 62%. And this is important because what it tells us is that the Global Compact is not a mysterious idea. It's not a pie in the sky idea. Instead, we're actually at a place where 62% alignment is a pretty good baseline to start from. Countries have taken huge steps that are really important, but also significantly more is needed. It's important to note that for each of the 10 indicators, there are countries where national law is aligned with the Global Compact. So national governments are doing this. Some areas are far more aligned than others. And so this is one graph looking at fair remuneration. And what we find is that most countries have just a baseline, at least, of national health, national laws and policies that are ensuring fair hours and minimum working standards for health workers, and that health workers are covered. We also find relatively high alignment when it comes to ensuring professional development and ensuring that that is in policy. We don't find that every country has, though, right? At least 13% of countries don't have anything on this front. On the other hand, some areas we find very low alignment. And so two pieces that I would call out here. One is health services. If we ask the question, do countries have laws that provide health services for health workers, including mental health and well-being, what we find is that while 69% of countries have some form of health services guaranteed for health workers, only 20% of those ensure that mental health and well-being are covered. 12% of countries in the world have no law or service provision for health care workers and for care workers. That's a significant problem in the world as we currently see it, given how often we see mental health emerging from some of the challenges. Similarly, in terms of low coverage areas, non-discrimination protections, only about 16% of countries have laws in place that cover all internationally protected areas when it comes to healthcare workers. And some countries do not have any laws at all that cover healthcare workers specifically. Next, I want to look at kind of two other areas, one of which was one that that was mentioned by Catherine, conflict protection and violence protection, that we find that 63% of countries have national laws and policies that incorporate all of the Geneva Convention protections for health and humanitarian workers, for health facilities, for transport, and for patients during conflict times. That is actually surprisingly low. To see that only 63% are fully covered. Some cover some of those, but not others, while 18% have no national laws that incorporate those nationally. Another area of kind of moderate level coverage is the protection from occupational safety, or occupational hazards. Our indicator here, we developed an indicator for each of these. Our indicator here is, do countries have instruments that cover all healthcare workers when it comes to occupational safety that at least includes access to PPE? We found that that was a relatively good tracer area. And what we find is that 70% of countries do have laws that are aligned, but 18% of countries don't cover all, don't explicitly provide for access to PPE, and 12% of countries lacked it entirely. On freedom of association, we find, relatively high coverage, but still only in the 70%. And when it comes to whistleblower laws, we found that there's a surprisingly large number of national laws that do not cover whistleblowers in any meaningful way. We also find a very significant variation when it comes to countries. What we find is that there are important areas where every single country has adopted some of the laws that are aligned with the Global Health Compact. But in every region, there are at least countries that are either at most indicators or all indicators. So this is not a regional question. This is every region's got countries that are the leaders in this space. Some of them in that space are Spain and Namibia, Brazil, Bhutan, and Canada that are relatively high adopters and can be leaders in the regions. But 5 of the 6 regions in the WHO spectrum have less than 20% of laws that are covered. You can see the full findings in the paper online. Now, countries do differ, and it's actually country by country where we see differentiation, not regionally. If you look across regions, generally we see somewhere between 55 and 60% of alignment with the CARE Compact across regions. And so often one of the questions we get is this just a prioritization of one region over another or one set of norms over another? We don't see that overall. Interestingly, the other kind of hypothesis would be rich countries are able to protect and secure the rights of their health workers, while low and middle income countries are not. And while we find some higher level of coverage among high income countries, it's barely significant. And we find that actually mostly we find that the big differences are between countries, including similar countries, including neighboring countries, not actually income level as a major driver. At every income level and in every region, we have some countries with high alignment and some countries with low alignment. I won't spend a lot of time on this because I'm sure there'll be moments to talk it through, but we have country examples from across the world. And so I would call out specifically laws in South Africa, Nigeria, and Brazil that explicitly ensure that community health workers have access to PPE, not just professionalized healthcare workers. That you've got work, and we're so pleased to have Jillian with us to talk about the Philippines, that thinks about continuing professional education. And you've got Kiritibi that's actually kind of leading in some Health and Safety Act issues. And so overall, the report that's out today shows that we can and have provided a baseline assessment of national laws on health and care worker rights and protections. That a third of laws are not aligned with the CARE Compact right now, which means we've got a huge opportunity for law reform globally. But of course, 105 countries are aligned with half or more of the indicators. And so this is a half full kind of report overall, which shows that law reform is a key piece of what might drive us toward better retention and better effectiveness of our health and care workforces. And it shows that countries are already leading and are going to be able to provide the way. There are examples of governments doing this already. I'll close by just saying that if you go online to htwpolicylab.org. You can see the paper in PLOS, a library of all the laws that we're talking about, as well as an online analysis of international legal instruments, and coming soon, a national assessment tool that will enable anyone that wants to, governments, unions, and others, to actually assess their own legal environment and take a much deeper dive than we've been able to do. And with that, I will turn it back over to you, Catherine. Thanks very much. And Catherine, you're on mute, so come on back.
Would not be a Zoom without somebody saying that one. Thanks, Matt. You win the prize. Thank you for that. And we can also see that people have responded to the quiz. I'm going to turn right over so that we can conserve the end for a robust discussion session to Dr. Atul Gawande. He's the Assistant Administrator for Global Health at USAID, a surgeon, professor, founder of a joint center for health systems innovation, and writer. Dr. Gawande and his team have supported the development of the soon-to-be-released Care Compact assessment tools and have brought the Care Compact forward with stakeholders committed to advancing the rights of health and care workers, protecting and safeguarding this valuable resource. Dr. Gawande, over to you.
Delighted to be here in my role leading global health at USAID and offering a few words. First of all, I cannot underestimate how significant the work the O'Neill Institute together with WHO has done in the course of creating this study. We have not had this kind of granularity of understanding how do we compare across countries what the conditions of healthcare workers are in terms of the legal and policy environment that they are working in. And this is transformative. We have been using a version of this tool in our global advocacy for the last year, working with Matt and Jim Campbell and team across this work. And I want to bring home a few key lessons out of that. Number one, we all as WHO member states have signed on to the Health and Care Worker Compact. It is a standard that we have all aspired to, but we've had no way to determine whether we are implementing those standards. Number two, now that we have this way to see how we're implementing those standards, we're seeing that it's perfectly capable, that our countries at every income level are perfectly capable of delivering on the Health and Care Worker Compact. And these data make, what are fairly abstract ideas like that workers should be fairly remunerated, they should be protected, there should be investments, and turn them into basic standards like, do your health workers qualify for a minimum wage in a given country? Are they included in PPE standards of care? And on down the list. Do they have health coverage themselves as part of their care as a minimum standard of what it means for protection? The second component I would say is that we are, out of looking at these tools, recognizing that countries at every income level, from Bhutan to Philippines to Canada, are working, are able to deliver across the pieces of the Health and Care Worker Compact. USAID, for example, has worked very closely with the barangay health workers in the Philippines around what's called the Magna Carta for health workers, which affirms the full panel of these laws, of these policies, and brings them into law in the Philippines. And we have supported the barangay health workers to advocate for those kinds of goals, and we'll get a chance to hear some of that example. A third critical point here is that that when we're then beginning to do this work, we have to be able to come together as a global community. It's been just over a year since we formed the Community Health Delivery Partnership. This is a partnership that has involved, that is co-led by USAID, UNICEF, World Bank, and WHO, among others, regional organizations like Africa CDC, and then member countries as well. And the donor partners like the Global Fund, Gavi, and so on, with an aim that we're able to coordinate around country plans for building better community health and primary health care. as part of that work, we have identified that we can use this tool to align on how do we set goals for working with countries to achieve particular goals here, such as achieving qualification of workers for the minimum wage. That means we have to unify across donors as well as with countries around how we push towards our remuneration, because in low-income countries, there is a very significant gap in this space, and there is work to be done to advance that. In Africa in particular, you have 85% of health workers are unremunerated community health workers, not getting that minimum wage level. And so we all have to be part of advancing to close those gaps and move that forward. That effort at donor alignment, as well as country and regional alignment around setting those targets and goals and then being able to advance along it, though this capability that the O'Neill Institute has built of tracking and monitoring will be important, not just for the snapshot that is there now, but for being able to see it as progress occurs in the future, to see how many more laws are in alignment and then whether policies are implementing those laws appropriately. Finally, I'll just say, we see more and more countries that have country-led plans for their global health security plans, for their primary health care, even for surgical systems of care. As we advance those plans, as countries advance those plans, we then around low and low middle income countries, donors and multinational organizations that are working to support are increasingly focused on being able to come in a organized, collaborative, collective way to be delivering on those goals. I just came from a meeting for 2 hours with the Ministry of Health in Nigeria, the Minister of Finance, the Minister of Budget, to make the case for the investment and protections, and work with our PEPFAR colleagues in the HIV space to come to agreements to join together in where they've established what they call a SWAP, a sector-wide agreement on the policies and plans for execution. And that has investment targets, policy goals, and goals of ultimately raising the outcomes of care. When we are talking about plans for strengthening systems, what we're really talking about are plans for strengthening health workers. Systems is abstract. Health workers are the system. They are the people who deliver the care. They are the ones who use the digital tools to deliver the care. They're the ones who need the supply chain to supply them. They're the ones who need the PPE to protect them. They're the ones who need the protections against attack and in conflict that we see all over the world. And those components are what we were working to bring to life just a couple hours ago in Nigeria. And this is the work that we're all having to do now around the world. With that, I'll send it back to you. Thank you.
Thank you, Dr. Gowanda. It's always a pleasure to hear from you. We now will turn to Dr. Gillian Roque, who is the Chief of Staff and Head of Organizing and Advocacy for Public Service's Labor Independent Confederation, a national confederation of government workers and their unions and associations in the Philippines. Public Services International have been strong contributors to development of the CARE Compact and its tools, and we look forward to hearing your insights, Dr. Roque.
Thank you for inviting us to this webinar. I represent PSLink. We are a national umbrella federation of unions of public service workers in the Philippines, and we are affiliated with the Public Services International, the Global Union Federation of Public Workers. Health and care workers make up a substantial number of most government workforces across the world, and PSI has a long history of organizing health and care workers into unions, pushing for enforcement of standards and better rights protection. Our health and care workers serve as the backbone of our health system. There can be no quality health services without health workers' rights. But in every part of the world, there are persistent gaps in the protection of healthcare workers' rights. And it is the women who make up the majority of health and care workers, our nurses, our community health workers, our caregivers, who suffer disproportionately when wages are low, when jobs are not enough, when jobs are informalized, when adequate PPEs are not provided, when staffing ratios are unsafe, when working conditions are unhealthy and dangerous, when care work is not valued properly, when care work is not recognized as work. And in many areas, public health care workers are denied their fundamental rights to freedom of association and collective bargaining. This is absolutely unacceptable. The right to organize and bargain is so fundamental in realizing all other rights. The lack of union representation, whether through explicit prohibitions or through intimidation and other disincentives, is a key barrier to decent work for health and care workers. And when health and care workers report wrongdoing and unlawful practices, they often end up suffering from retaliation for lack of whistleblower protections, law, and enforcement. Rights violations against health and care workers can happen anytime and anywhere, and it's important that standards are in place to ensure that we are protecting the people who are responsible for providing the health and care needs of everybody else. By ensuring robust legal and policy environments, we are protecting not only their labor rights, but also the right to health care of everybody else, including the most marginalized sectors of our society, the youth, women, elderly, persons with disability, persons of diverse socioeconomic, and the poor. It is when workers unionize that they are able to fight for their rights at work, ensure implementation of policies, and bargain for better conditions for patients also, including improved staff-to-patient ratios and life-saving interventions. As the Global Federation of Health and Care Workers, PSI is leading efforts to ensure fair pay, decent work, equality, and non-discrimination in the healthcare sector through organizing unions, building workers' power to represent, negotiate, and lobby for their rights. In the Philippines, despite the killings of unionists, harassment, red tagging, and other attacks on freedom of association, making our country one of the top 10 worst countries for workers in the world, PS-Link, together with the other PSI Philippine affiliates, have successfully lobbied for the ratification of important conventions on occupational health and safety and elimination of violence and harassment in the world of work. PS-Link also compelled the government to raise the salary grade of nurses due them after filing a petition at the Supreme Court. Sorry, please, yes. So those are just some of the slides showing our actual actions. And as the Philippines is also a major country of origin of migrant health workers, we have been leading efforts to promote rights-based bilateral labor migration agreements, ensuring fair and ethical recruitment practices aligned with the WHO Global Code of Practice on the international recruitment of health personnel. Next slide, please. Next slide. Across the Asia-Pacific region, PSI affiliates are showing how healthcare workers are organizing to win. The Maldives Health Professionals Union has recently won significant pay increases for health support staff. PSI is also organizing community health workers who are often marginalized, unpaid, and excluded from labor laws and social protection. PSI's recent success in organizing the first National Community Health Workers Union in Pakistan. Next slide, please. Next slide. Oh, and this, please move back. Oh, and so that shows you the photo of yes, okay, so that shows the photo of where the PSI affiliate in Pakistan organized successfully 20,000 community health workers in Pakistan, the first national union. And then PSI also successfully affiliate in Nepal also successfully negotiated for community health volunteers to be recognized as workers with rights. These are testament to how unions are making real changes on the ground, leveraging international labor standards and improving the lives of our health and care workers, leaving no one behind, including our community health workers as well as migrant healthcare workers. The Global Care Compact and assessment tools are very important tools, and they come at a crucial time when health and care systems around the world are grappling with multiple crises, from pandemics to extreme weather events and disasters due to climate change, to social and economic inequalities, to aging population, to rising wars and conflicts. But just like any other tool, they're only effective when they are used. And PSI, which has actively contributed to the development of the Care Compact from the beginning, is very much committed to using it, leveraging it to build workers' power. As public sector unions, we will continue fighting for workers' rights and social justice for all, and put people over profit. Thank you very much.
Thank you, Dr. Roque. It's great to see that you're fully behind as you've been contributing throughout. I'll turn directly, after highlighting the fact that we are really enjoying seeing your answers to the polls and quizzes, and we would like to see your questions in the Q&A. We're looking forward to answering those as well. I'll turn this over to Dr. Letitia Rispel from Wits University in Johannesburg. Dr. Rispel holds a research chair on the health workforce and is also a member of the WHO Expert Advisory Group on the relevance and effectiveness of the WHO Global Code of Conduct on the international recruitment of health personnel. It's, I think, the longest thing that we have in our department. Dr. Rispel, we're really looking forward to your insights.
Thank you very much, and good afternoon to those of us who are in the afternoon, and good morning to many of you in North and South America. So firstly, I would like to congratulate the leadership of the World Health Organization for jointly with the O'Neill Institute for doing this very important study. I think the study is very important in advancing the debate or the discourse on worker protection and rights. One of the things that struck me from Matthew's presentation was the variation across regions and countries. And because I'm in the Africa region, I was particularly interested to note that only 55% of countries in Africa, or roughly 1 in 2, have aligned laws where health workforce, and why it's significant in the Africa region is when we look at the projected shortages by 2030, it's the one of the regions where there's millions of projected shortages of health workers. It's of course also one of the regions, WHO regions, where there are numerous challenges, particularly suboptimal working conditions, which are often most acute in the region and often serve as a push factor for health workers to migrate. But globally, when we look at the figures that were presented, fewer than 25% of countries, or less than a quarter, are fully aligned on access to health services in occupational settings and equal treatment and non-discrimination. So what is important about these findings is, of course, there's an intersectionality where these issues all connect. But I think these gaps, particularly in the lack of alignment of legislation on access to health services or on occupational health services and equal treatment and non-discrimination, have implications, particularly for strategies to achieve gender equity. We know that when we look across the world from some of the reports that have been published by WHO itself, roughly 70% or more of health workers are women. And so, so I think the findings have implications for achieving gender equity. And given particularly the expert advisory group that's been established to look at the code, the International Code on Recruitment of Health Personnel, it also has some of the lack of alignment has implications for the protection of migrant health professionals. But having said that, this study, I think, is very important in realizing the vision of the compact, because laws, today is International Human Rights Day. We all know that laws or legislation are an important precondition for the protection of health and care workers. But as Gillian said shortly before me, is that although laws is an important precondition, often the Achilles heel of enabling legislation is often lies in the implementation. And I know that very well, coming from, from South Africa, where we have one of the best constitutions and among the best laws in the world. And incidentally, I looked at the findings on South Africa, and South Africa, in fact, performed very well when you look at almost all the indicators that were used in this analysis. So in conclusion, Catherine, I think the study findings make the case once again for health workforce investment, particularly dedicated financing. I think it also makes the case for the implementation of the various WHO resolutions that were approved by member states. And of course, it also makes the case once again for those strategies that are contained in the Working for Health Action Plan that was again approved by member states in 2022. So thank you very much, and over to you.
Dr. Rispel, thank you. That was an outstanding analysis, and we'll have to have you as the ambassador for the PLUS paper, if not for the entire compact. Delighted to have you on board. Our final panelist today is Jim Campbell, who leads the WHO Health Workforce Department. He may be a familiar sight to some of you, but for those who are not, you're in for a treat. Jim oversees the development and implementation of evidence and tools to support countries in educating, employing, and retaining the health workforce. Jim, over to you.
Thank you, Catherine. Good morning, good afternoon. Let me just echo my appreciation to the O'Neill Institute, USAID, Public Services International, our academic friends and colleagues around the world who have all contributed to the development of the Health and Care Worker Compact, the development then of the portal and the policy tools to assess country practice, and this study, the creation of this first baseline. Matt, appreciation to all O'Neill at all, to appreciate them at USAID. It is, we obviously, the sentiment for the Health and Care Worker Compact came during the COVID-19 pandemic, when we saw hundreds of thousands of health and care workers being impacted in terms of moral injury, mortality, morbidity coming through that COVID experience. And these protections and safeguards confirmed in a resolution on that name, enshrining some of what we believe in terms of the Universal Declaration of Human Rights and broader international health law, international human rights law. And now we're at the stage where, okay, we're going beyond the political will into an evidence-based policy perspective around this to drive it. 4 points, if I may, Catherine, just to add to the excellent contributions of other panelists. You rightly say, firstly, health systems are under huge challenge. Population aging, conflict, humanitarian disaster, climate disaster. This is a given, and we have to respond. And as Atul says, as a global community in solidarity around the world around some of these issues. Those demands, second point, are being transferred on to health and care workers worldwide. We see that, and we're seeing the issue of that. And as Matt has rightly said, we need to understand that these protections and safeguards are a determinant of the optimization of those teams of workers. They're a determinant of the retention, the attrition, as Letitia was saying, the push factors. If we don't treat health and care workers with respect, they will make other choices in terms of where they work, how they work, in which country they may work. Thirdly, let's look at then the impact, and Letitia really get this. We've got new numbers, which will be a key point of discussion at the executive board next year and for member states. What has happened? We knew we had a global shortage of 18 million workers for the SDG era. That came down to 15 million pre-COVID, and we anticipated that we would continue to make progress to bring that down to about 10 million by 2030. But that still means in many health systems, workers are understaffed, under-resourced. However, COVID has impacted that progress. What the estimates now suggest is that the pace of progress has stagnated. That 10 million that we were working towards is no longer on track. And we're going to have a greater shortage of 11 million workers coming forward. So again, in this next 5 years of the SDG era to 2030, systems will not have the capacity to respond to the demand, transferring the burden onto the workers that we seek to protect and safeguard. In which case, what actions we've taken? This is the fourth point, really. The first action has to be to invest in today's workforce, to seek those protections. It's Human Rights Day, and everyone recognizes health as a human right. But let's think about the worker perspective. Do they have the access to fair remuneration? Do they have the decent work provision? Do they have the social security? Matt highlighted that access to health services packages in the event of injury are not there. Do we have guarantees around periodic holidays and the limits to working hours at all? It's confirming. Many occupations, community health workers, community health volunteers without those protections and safeguards today. So our first investment, invest in those who care for us, invest in those that we anticipate to carry a burden around some of the weak health systems around the world. The second investment, let's make corrections. Evidence is telling us that we've got a global shortages, many low and middle income countries adversely affected, understaffed, under-resourced, unemployed workers. So let's get the additional investment. Atul, it's wonderful to hear that USAID working with Nigeria and other countries to seek those insurances for that additional investment into education, into employment, into protection, which gives us retention. And that's the key elements here. And as Letitia rightly said, and as Gillian has highlighted from the Philippines and elsewhere through the Public Services International, let's not forget that around the world, 2/3 of our workforce are women. And that often there is a clear association between weak health systems and the transference of burden and the lack of protections for health and care workers because of this large share, because of their gendered nature, the feminization, that we often see an association between poor pay, poor social security, poor conditions of work for women. And this is, it's an obligation for all of us on Human Rights Day to make sure we protect all workers. But when we see the association with women workers and with poor protection, we should be additional engagement to take action and course correct. So once again, thank you. It's a wonderful undertaking. Hundreds of people involved from countries, from regions, from academics, from legal groups. The O'Neill Institute is a collaborating center helping us really drive this work forward. We often get ministerial commitment in the World Health Assembly, but then it's a partnership to turn that commitment into action. So thank you very much. Thank you.
I'm going to take a quick opportunity to highlight a related note to what you were just discussing, which is gender. As you know, our WHO official statistic is 67.2% of the global health and care workforce is composed of women. So I'm going to actually pass the question first to Matt and then just ask Jim to add one or two quick thoughts on the topic of gender. Following Rusa's question, I wonder if you found differences in protection levels by gender of the occupation. For example, are male-dominated professions such as surgeons better protected than than gynecologists, nurses, midwives, female-dominated professions? Matt, I'm going to give you that question, and then Jim, I'd like you to just jump right in and perhaps highlight recent reporting that's been done on female participation in the workforce and in the care workforce.
Thanks, Catherine. So we don't have full visibility onto that question, and I think it's actually a really excellent one, right? What we do know is that we've done some deep dives into community health workforce, we've done some deep dives into care workforce specifically, and we do absolutely find that in the less formal occupational groups, in the less recognized and less lauded occupational groups that are disproportionately staffed by women, we do see less protections. And that comes in a couple of different places. We certainly see that when it comes to remuneration protection. We see that when it comes to the formalization protections. And we see that when it comes to some of the collective bargaining protections that are available. And so I think that does have a really meaningful point when it comes to how do laws drive gender equity or drive gender inequality. And so here, right, on its face, as you all have been sensing, on its face, you would think different occupational groups might logically have different legal infrastructures. And to some degree that matters. But what the Care Compact gives us, I think, is a broad way to understand what's a baseline. Because I think one point that is worth really making about this is these kind of recognitions that we're giving, they really are a baseline. When I say 62% of countries are aligned with the global compact, the global compact is a vision, and we're saying, do you at least have this kind of minimum pieces in there? And so what we know is that actually a third of countries don't even have the very minimum basic pieces there, and those are disproportionately kind of falling on the different cadres. What we're hoping over the coming year to 2 years is to be able to do a deeper dive into the specific groups within the occupations to really understand how that might be driven. But I think this gender question is a reason to do that even deeper in a very crucial way because of how that drives gender inequality.
Jim.
Yeah, Catherine, just, we just published some new data. There's 67%, obviously, that people cite around the percentage of women in the health and care workforce, global number, a bit like the 62% Matt's saying there in terms of all the different instruments. But we've got to come below that. Latest data, for instance, that we just published last month, in the Eastern Mediterranean region, we've only got 43% of the workforce are women. So it's the majority in that region are male. So you've got to come there. And then you look at the different occupations. Medicine, nursing still high in the EMRA region, around 85%. Medicine, physician workforce, even lower, down at 38%. So you've got to go beyond these big numbers and come down. So the question that was posed in the chat there, the Q&A, absolutely relevant. But this is where, as Matt said, we've got to come down to the national analysis. So taking the policy instruments now and saying at the national level, let us look a bit deeper into these issues, whether that's on the fair remuneration of volunteer workers, people who are doing 20, 30, 40 hours a week, providing healthcare to communities. Are they being paid? Doing that piece, or coming back to the gender disaggregation, coming back to the social security health service, and getting that additional level of detail. This evidence base, if we make it public, if we make it transparent, we put it into the policy domain, we can then have informed action.
Thank you for that, Jim. And following up with that gender lens and also on looking at specific occupational groups, while I'd like to highlight that the CARE Compact really looks, as Matt pointed out, broadly at all health and care workers, there have been some studies done on specific occupational groups, and I'd encourage the stakeholders here to think about where you could apply this to your occupational group, and we are happy to accompany you on that. I'm not certain whether to point at Matt or point to the very helpful Dr. Gawande, who has also posted a question on this, but we have a query with regard to the extent to which our research found laws that covered community health workers, and if yes, where? So Matt, let me give that briefly to you, and perhaps I could ask the host to highlight in the chat the link that Dr. Wande very kindly shared.
Absolutely, Catherine, thanks. And let me just show, and I would love to hear Atul to come in on this as well. You know, this is just one slide from the report that that USAID supported within the Community Health Delivery Partnership. And what we find overall is that most every country in this short, this subset of countries that we did an analysis of, has the recognition of community health workers as part of the health delivery groups, but don't necessarily, one, legally classify them formally as workers. So even where they're describing their duties, et cetera, they don't necessarily give them the rights of being formal workers. And CHWs are disproportionately in contexts, the ones who are not guaranteed a minimum wage, and remarkably very few countries of this small subset actually guaranteed community health workers adequate PPE and unemployment protections and benefits. And so that is one area where we not only see a wealth inequality, but a gender inequality because of the way in which the community health workforce is broken down. These are among, obviously, the most vulnerable of our health workers writ large. And so thinking about that as a core bit of how would we improve the post-COVID environment for responding to disease, for responding to pandemics, not to mention the delivery of primary care. I do think that this makes a very strong case for a set of law reform as something that is crucial for human rights and crucial for the delivery systems that we rely on when those pandemics hit.
I will just jump in to add one thing, which is count on Matt and the O'Neill Institute to have the data on it. And I would point you to the Community Health Delivery Partnership report, which not only included his analysis, but a range of inputs from different actors in this space. And I think it's the most comprehensive report I've seen about what are community health workers, what status do they have in different countries, what kinds of functions and services are they providing, how many are part-time, how many are full-time, and those other considerations. So just glad that the link on community health workers is the report has been posted and recommended to you all.
And while I've got you, you have, of course, worked in the U.S. health system, and now in this role at the global level, what do you see as the big questions that bridge global north and global south when it comes to laws that really ensure that workers are retained and succeed at their job? Are there things that countries like the U.S. have to learn from countries of different socioeconomic backgrounds that could be taken forward?
Yeah, things is just the recognition that you can have healthcare worker protections, but and in law, but you also have to implement them, and you have to implement them consistently. And so it's one thing to have the laws and the policies on the books; it's another to have appropriate implementation. Second is that we actually have low use of community health workers. And what you find in countries across the income spectrum is that when you accompany a primary healthcare system with an outreach workforce that actually physically visits people and their households on a regular touch point basis. That's the only way you're able to get to public health goals and good appropriate care. For example, during the COVID pandemic emergency, getting elderly vaccination up over 95% simply was not achievable in the United States until under the Biden administration, there was the financing sent to states to hire what ended up being more than 150,000 community health workers hired from local communities, especially in the vulnerable areas with low rates of immunization. And that was how that direct connection, offering immunization, pulling people who were lost to care into the care system, ended up getting the vaccination rates to 95%. We have that same need across areas like hypertension, the biggest killer in the world, but inadequately diagnosed or under appropriate treatment. You can go on down the list, assuring appropriate immunization levels, prenatal care, and so on. And in the and you see across income levels, that ability to have that health workforce for outreach is how you get those things done.
As a former community health worker myself, I really appreciate that focus on primary care. Dr. Rispel, I think this is probably really well suited to you. Are there studies on the relationship between health insecurity and quality of care? And how can we incorporate some of this thinking? And I would actually broaden the question, if I may, to how can we incorporate knowledge of the Global Health and Care Worker Compact into health professional education and health worker education?
Thank you, Catherine. So I would refer, the person who asked the question. In 2018, you may recall that there were 3 global reports on quality that were published. The one, in fact, was that was done by WHO and OECD. It focused on achieving quality. What were the key indicators for quality? The second one was the Lancet Commission on achieving high quality health systems as part of universal health coverage, that was chaired by Margaret Crook. And some very important aspects there. One of the key strategies that was listed there was around the importance of investing in the health workforce, both pre-service education as well as continuing professional development. And the third report was one that was published by the National Academies of Science in the United States, which also focused on high quality health systems. So obviously, I don't have time to talk about all of those. Safe to say that they put different emphases on the health workforce. So for example, the one of the National Academies in the US put a lot more emphasis on community health workers and the importance of incorporating or integrating community health workers into national health systems. But all of them certainly highlighted the importance of the health workforce in delivering, quality of care. With regard to how do we incorporate some aspects of the compact, I think some of it is already, there's obviously certain elements that's already incorporated into pre-service education in particular. But I do think sort of in moving forward, the whole global emphasis on the Health and Care Worker Compact, its implementation and the importance of investment in the health workforce, we need to continue to advocate for its integration and also continue to highlight the intersectionality of all of these aspects in achieving universal health coverage, which, as all of us know, is a target of the Sustainable Development Goals. Over to you.
Wonderful. And there certainly are links to be made between our global health ambitions and how we implement them, and how we invest in the health workers that deliver them. Jillian, I have a question from Health Policy Watch. What international recourse do health workers have if their rights are undermined in their own countries? For example, health workers being unable to get COVID vaccines or Mpox vaccines if their governments are not supporting those immunizations.
At the international level, trade unions are using we're using the ILO to address issues related to work. So if it's related to occupational safety and health, we already have international labor standards that cover that. So that can be a space where you can report cases of violations of labor rights.
Thank you. Now we are coming to the very end of our time together. I really appreciate the questions that we have gotten, and we will be adding more to the Q&A in our follow-up. We'll be sending you all an email after the Zoom. I'd like to take the opportunity now just to give each of our panelists 1.5 minutes, 90 seconds, to just do a summary of your key insights from our discussions. I'll start with Matt, Dr. Cavanaugh.
Great. Well, thanks all for joining this. It's been such an interesting and rich conversation. The kind of thing that I would just leave with is that, if we believe as the world that post-COVID, one of the drivers of why countries did well in COVID, why countries did poorly in COVID, which I think is really clear. One of those drivers is certainly the health workforce. Where the health workforce was able to do its job well, where it was able to succeed, we very clearly saw that those were countries that were able to achieve things that other countries were not. And then to Atul's point, where that health workforce was, strategically deployed and at the right level, that's one of the sets of things that's really crucial. And so too is this piece that how do we keep people in their jobs and being effective? As we looked at laws in these 182 countries, what we saw is that clear things like, are you able to take a sick day, right? If you need to, which we know is tied to health workers not only staying in their job, but being good at their job and ideally not spreading infectious diseases. Those kinds of things are things that should be in law. And some countries are doing it really well. Some countries are leading in every single region, showing that we're not talking about things that only wealthy countries can do. We're not talking about things that only countries in Asia can do or only countries in Europe are doing. But in fact, in every single region, you've got some countries that are doing it. But in that space, law reform is very clearly a piece of what should be on the national and the global health workforce agenda in a way that it hasn't been to date. And we're hoping that this piece contributes toward our core understanding. This shows us that it's not all health worker issues that need to be addressed, and that in fact, some of them really deeply need to be addressed, while others need perhaps less attention. And so really focusing in on where does each country think it can make progress on improving retention, improving effectiveness through ensuring the rights and protection of health workers. That's what we're hoping to inspire over the years to come with the data that we've got available and the tools that WHO is making available as well. So thank you all.
Thank you. Dr. Gawanda, Atul.
Thank you. I'll just start by saying, or I'll finish by saying, we all know you cannot improve what you cannot measure. And that's because you cannot improve what you do not see. Measurement is how we see what is real and happening in the world. To improve health systems, you need to be able to see and measure the health workforce and not just count numbers of them, but know what their conditions are like. And this work is groundbreaking and a really major advance precisely because it allows us to see and measure in more careful detail the actual status and experience of health workers. There's much more that we can know, but this is a major leap forward. So thank you to the team and thanks for the chance for participating.
Thank you. Dr. Roque, Jillian.
Thank you again, for inviting us to this webinar, and thank you for this very important study. This baseline assessment really provides us much needed evidence that we can use in the labor movement to support our lobbying efforts to address gaps in policies. And it's particularly useful in building our case to prioritize health workers' rights, especially recognizing care work as work and recognizing our community health workers, the need to protect them and also the need to cover them under existing labor laws. And we also hope that the WHO will also continue to engage the trade unions in advancing the Global Compact and the assessment tools.
I think you can count on that. Dr. Risbell, Letitia.
Thank you. So my two quick take-home messages that I think are shorter than any of the other panelists. Firstly, that this study demonstrates the transformative potential of laws to protect health and care worker rights. And secondly, we must always remember that health and care workers are the personification of the health system, and we in turn have the responsibility to take care of them. Thank you.
Thank you. Jim Campbell.
So again, I'd just like to, a couple of points. I'd just like to say thank you. This is a partnership of legal specialists, international humanitarian law academics, governments, development agencies to make the difference, because it is through putting data into the public domain that we can start to have a global dialogue, and then we can start to look at the practice gaps. And there are some of the questions also, you know, this is the policy instruments is one thing, but the practice gaps need to be determined at the national. Is every public employer ensuring that they're doing? Is every private employer, of the small businesses, the large businesses, all compliant equally? We need to come down through this partnership and putting the information into the public domain. Absolutely essential. Then we can start to answer some of the other questions. You know, when we get fair remuneration, what's the impact of that fair remuneration when it achieves one of the policy lessons? With a really good question there around Liberia. What we're seeing is, as we start to make work conditions better, do we see more men taking those jobs? So is there a distortionary effect created when we put rights into the workplace? And again, shine a light on that. This is not, we want to pay people properly. We don't want to take volunteer women out of the services and put paid men in their place. So to really look at that. And the final comment would be, really, this is just the start. The study, the baseline, all the work we've done from ministerial consensus, data-driven evidence, baseline study, the work now starts. Join us, get engaged. Whether it's working with O'Neill, whether it's working with Letitia, working with PSI, get engaged, help us get more context, more national assessment into the public domain. Thank you.
Thank you, Jim. And thank you to all of the speakers. I'd like to take this opportunity to recognize the outstanding panelists that we've had today, both presenting the evidence and reflecting upon it. As my august leader often says, health workforce is a team sport, and so is taking forward the Global Health and Care Worker Compact. We will be releasing the assessment tools at the beginning of next year. We will really look to partners, stakeholders to come together with countries, with national governments, come together and assess where you are and find opportunities, not only through knowledge sharing, but also through revision of laws and policies and making those commitments to where we can work together. I'd like to make just a special thank you, however, to the team that has really made this happen. Eric Friedman has been involved in the CARE Compact since it was the germ of an idea, and he is sitting there behind the Q&A, modest as ever. He's joined by Vishak and Varsha and Luis and the O'Neill communication team, who have, including Cassidy, whom you got to see at the beginning of this discussion, who have really made this all possible. We are a team sport, and we really look to all of you to join us in making this a reality and pushing it forward, in working with governments, in partnering, advocating, fighting, but doing whatever we need to do to make sure that the world for health and care workers is safe, and that we realize the promise of Human Rights Day, Health for All. Thank you all for your time, and we'll be in touch soon.